maneuvers. There are different maneuvers to increase the vagal tone, to look for the P wave, to reduce the ventricular rate, to look for the P wave, but some arrhythmias are diagnosed. So first case one, this 60-year gentleman, he presented with pneumonia and this type of rhythm. So it's a narrow complex tachycardia. The RR is irregular and there is no visible P wave. There is no visible P wave. So the diagnosis is atrial fibrillations. Next, this case. This is a 30-year male. He presented with palpitation and ECG was suggestive of a narrow QRS tachycardia. Rate was around 50 and there was something hit which was present after the T wave. So my resident, he made a diagnosis of supraventricular tachycardia and give him adenosine. And after that ECG results. So this maneuver increased the vagal tone and give so large the P wave. And the P rate, if you see, it's around 300. So it was atrial flutter with twist on AV block. Now it has been converted into atrial flutter with fixed AV block. 40 years female presented with narrow QRS regular tachycardia. If we see, we can see the retrograde P wave here. And that's a short RP tachycardia, but RP is more than 70 milliseconds. An electrophysiological study was done which showed a long VA tachycardia and it was diagnosed to be atypical AVNRT and later it was updated. A 30-year female presented with narrow QRS tachycardia. It's regular and as such there is no visible P wave. But if we can see the lead V1, we can find some progression of upstroke after the S wave. So it is called pseudo S pattern and it's diagnostic of typical AVNRT. Again, a 30-year-old boy with diagnosis of dilated cardiomyopathy came to us with this ECG. If we can see, there is regular. It's narrow complex regular tachycardia and there is visible P wave. The P wave is upright in V1 but it's negative in 2, 3 and AVF. And it is long RP tachycardia. It is diagnostic most probably of atrial tachycardia. Now white QRS tachycardia. Usually when a heartbeat is originating in the sinus node and it's conducting to the ventricle, the QRS complex is narrow because it's being conducted through highly specialized conducting system which has high conduction velocity. So QRS depression which reflects the depolarization time of the whole myocardium is narrow. It can be wide if the tachycardia is originating from the ventricle, it's ventricular tachycardia, or in sometimes ventricular tachycardia can be narrow, that I will show you. Then it can be cutaneous supraventricular tachycardia which is conducted to the ventricle through some conducting system which is diseased, so it's either conditional block or it's IVCD, or it can be wide if the supraventricular tachycardia is conducting through to the ventricle, to the bypass, through the bypass tract, bypassing the AV node. So these are the differential diagnosis of white QRS tachycardia. Now let's see how to diagnose. First thing, it's regular or irregular. If it is irregular, it's just look for the morphology of different QRS complex. If it's irregular and the morphology of the QRS complexes are same, then it is either atrial fibrillation with a bundle block or it's atrial fibrillation which is conducting through the bypass tract. But if it is irregular and the complexes are multiformic, then it's a polymorphic ventricular tachycardia. Then AV dissociation. It's very difficult to look for AV dissociation in presence of first ventricular rate. But if there is any AV dissociation, it's suggestive of ventricular tachycardia. Then the precordial concordance. Precordial concordance means all QRS complex from V1 to V6, either it is negative or it is positive. If it is negative, 100% sure it's ventricular tachycardia. If it is positive, it can be ventricular tachycardia or any SVT which is conducted through some prostaceptal bypass tract, the ventricle. Then capture bit. What is capture bit? It's a narrow QRS in between the white QRS complex tachycardia. Presence of capture bit is suggestive of ventricular tachycardia, but it can also be seen in patients with SVT or atrial fibrillations with bypass tract. I will show one example. Then is fusion bit. Fusion bit is just a fusion between the narrow QRS and white QRS, which suggests to ventricular tachycardia. Then the QRS duration, QRS axis, and QRS morphology. If we go through this step-by-step approach, we will be able to diagnose ventricular white QRS tachycardia in most of the cases. Now, the case-based example. Now, there are some points regarding QRS duration and axis. If a patient with white QRS tachycardia and RBB morphology, if the duration is more than 140, ventricular tachycardia is likely. If with LBB, the QRS duration is more than 160, ventricular tachycardia is likely. And RBBB with left axis or LBBB with right axis is suggestive of ventricular tachycardia. Extreme orthodox examination where the QRS complex is negative in both 1 and AVF is suggestive of ventricular tachycardia. And if we get an ECG with normal sinus rhythm and ECG with tachycardia, if there is a significant deviation of the axis, that means it's a ventricular tachycardia. Now these are some QRS morphology which are suggestive of ventricular tachycardia. In patients with RBB morphology where the V1 is positive, if it is monophasic or it's biphasic with small q followed by large R, it's ventricular tachycardia. But if it is triphasic, it's supraventricular tachycardia with a C. In patients with LBBB, if this type of small narrow R followed by rapid S, it's suggestive of SVT. But if there is a wide R and there is a slow descent, then it's suggestive of ventricular tachycardia. So this patient is 40 years old male, presented with syncope, and on examination his blood pressure was 80 systolic, and this type of tachycardia. It's white QRS, it's irregular, and the QRS complexes are almost of same morphology, and there is one narrow QRS. So the diagnosis is most probably it's supraventricular tachycardia, atrial fibrillations with a bypass tract. So the patient was decided to show the delta in the normal sinus rhythm. So it was atrial fibrillations with bypass tract tachycardia. Now these patients, again white QRS tachycardia, QRS morphologies are irregular. That was suggestive of polymorphic ventricular tachycardia. This patient was decided to show that there was deep T-wave inversions with prolonged QT interval. So this is a diagnosis of prolonged QT with pulsates, and this patient was decided. Now this 45-year gentleman, he presented with incessant palpitation for last 10 days. He was decided 6 times before coming to us, but there is no solution of the problem. Now ECG, his blood pressure was well controlled, it was 0.20 by 80, and ECG showed there is a white QRS tachycardia, it's regular, and there is RBB morphology, and if we see in the view 1, it's monomorphic, and there is a narrow QRS, that's a capture bit. And if we can see this is a P, this is a P, so there is some AV dissociation. And axis, again, axis is northwest. So the diagnosis was ventricular tachycardia, most probably LV origin. As the patient was resistant to DC cardioversions, which different pharmacological therapy, and the rhythm was controlled in a combination of amiodarone and phenytoin, and that showed the rhythm. The patient was having left dominant arrhythmogenic cardiomyopathy with left ventricular tachycardia. Now 51 years female presented with syncope. ECG shows white QRS tachycardia. PUFs are not visible. It's very difficult. In this case, it's fast step. It's very difficult to look for AV dissociation. But if you can see, there is precordial concordance. From V1 to V6, QRS is negative. So, the patient was having ventricular tachycardia and she was dissipated. This is a 40-year gentleman who presented with incessant palpitation and he was controlled with phenytoin. And if we see the ECG, it's RBO morphology. The V1 is monomorphic, the axis was left, and a diagnosis of ventricular tachycardia was made, and it was reverted to phenytoin with normal sinus rhythm. This is the 24-hour Holter monitoring of a young female, a 6-year female, is presented with heart failure, and her ECG was showing some ectopic, so Holter was done, and Holter showed she was having its RBU morphology, but it's narrow complex, and if you can see, this is a P wave, and there is AV dissociation. So it is suggestive of ventricular tachycardia. It's narrow because it is originating from the specialized conducting system of the heart, and she was managed. Initially, she was in class 4, her LV was 20%, and BNP was 2400, she was managed. And the arrhythmia was controlled with a combination of phenytoin and beta blocker. And 2 months after the presentation, she was class 1. There is no ectopic, no tachycardia, and LV ejection fraction improved from 20% to 35%. So she presented with recurrent ventricular tachycardia with tachycardiomyopathy. This is the last ECG of this. So is a young female. She is a student of class 12. She presented with palpitation. So it's a regular QRS tachycardia, white QRS, regular tachycardia. The axis was left. But if we can see the V1, it's a narrow upstroke followed by narrow R followed by rapid S. So it was a supraventricular tachycardia with aberrancy. She was given adenosine, she responded to adenosine. Later, the study was done. It was suggestive of mild tachycardia and she was ablated. Now, this case is a young guy, he is 11 years old. He presented with exercise-induced palpitations. So, ECG shows that white QRS tachycardia with RBV morphology. RBV morphology with the first notch is larger than the second notch. It's known as Rabbitier sign and it's suggestive of ventricular tachycardia. You can see also one capture bit. So, it is a ventricular tachycardia, but the axis is being changed. The axis is continuously changing. So a diagnosis of bidirectional ventricular tachycardia was made as the patient was hemodynamically stable. He was stabilized, he was reverted to sinus rhythm with a combination of beta blocker and flecainide. And after that, after conversion to sinus rhythm, it shows a large Q wave. This is the T and this is a large Q wave. And the patient was suffering from a rare genetic channelopathy. It's known as Anderson-Tawil syndrome. So bradycardia, again, if the rate is slow, look for whether it is regular or irregular. If it is irregular, either it is sinus arrhythmia or it's ectopic one-ring pacemaker syndrome, or there is any AV block, that is type 1 secondary AV block. Now the POA morphology, whether it's originating from sinus or there are multiple POA morphology. The PPR is relation, whether it's 1:1 relationship. If there is 1:1 relationship with bradycardia, either it will be sinus arrhythmia or it will be sinus bradycardia or it will first degree heart block. But if the PQRS basis is altered, if there is more POF, then QRS complex, then either it is a second degree or third degree AV block. Then the PR interval, whether it is fixed, whether it is prolonged or not, whether it is varying, and the QRS morphology of the QRS escape. So this is a common ECG, and young male who is an army guy, he presented with some hernia, and ECG was done in PSC and is referred for irregular heart rate and long pause. So it shows that the PO morphology is same, but the rate is varying, PP rate is varying. So this is a case of sinus arrhythmia, and it's common in patients with high vagal tone. Now this ECG, heart rate is irregular, and the POA morphology is varying, and PR interval is also varying. This is suggestive of wandering pacemaker syndrome, but the pacemaker is shifting from one side to another within that chain. Now, this is a case of regular bradycardia 1:1 relationship, PQRS relationship, POB is normal morphology, and PP is reduced. So it's a case of sinus bradycardia. This is the case of bradycardia where the rate is irregular and the rhythm is irregular and there is not one-to-one PQRS relationship. This is the PR, this is the PR, this is the stride increasing, there is a drop. This is suggestive of type 1 second degree AV block. Now, this ECG, it is the QRS is wide and the PR is fixed and there is a sudden drop. This one P is not conducting. So it is type 2 second degree AV block. And for this ECG, there is the P, there are multiple P's which are blocked and the QRS complex is wide. So it is complete heart block with wide QRS escape. At last, this ECG is a bradycardia